So welcome everyone in today's Diabetes Dilemma session, as these are fortnightly programs of experts' views, and it mainly consists of interesting clinical topics where we discuss all the issues related to our day-to-day problems when we write prescriptions. So a bit about today's program, which we are discussing about different diuretics and in particular about chlorothalidone, and we have two great experts with us, Dr. Jagdish Hiremath, cardiologist from Pune, and Dr. Valentine Lobo. I will formally introduce them in a minute. This is our webpage, and on www.diabetesdilemma.com, every time you will see this upcoming program, and below the upcoming program, you will see the invite of that day's event, where one can join directly by clicking on Join Webinar. You don't need to subscribe to Diabetes Dilemma to join today's event, whatever is the upcoming event. To view past programs, one needs subscription, which we can do it again on web page. So today I am privileged to have Dr. Jagdish Hiremath as an expert today, which he will be speaking about hypertension, diabetes, diuretics, particularly about chlorothalidone. Dr. Jagdish Hiremath is an intervention cardiologist. He is DM, DNB, FACC, highest cardiac qualification in India. Actually, he doesn't need this qualification when we are introducing him. We all know him, experience of 31 years of wholesome cardiology, which include prevention as well as intervention. He specialized in coronary angioplasty and heart failure. Special contribution to echocardiography, as we all are aware that many of the his colleagues, cardiologists, send all patients on special echocardiography to Dr. Jagdish Hiremath. He is pioneered in echo Doppler, PTC and heart transplantation in Pune, teaching professor of cardiology in Pune Hospital, Bharati University, and chair professor of preventive cardiology, Maharashtra University of Health Sciences. He is author of a monograph Coronary Angioplasty and honorary editor of Circulation Indian edition. Principal investigator in many prestigious international trials. Presently, he is holding a position of Director Cath Lab Cardiologist of Heart Transplant Department at Ruby Hall Clinic, Pune. He is also a member of PMC COVID Task Force. So, I am very happy and privileged from Diabetes Dilemma platform that we have such a great expert. So, I am sure I can see some questions in the question box. So, I think people are already logged in. We also have Dr. Valentine Lobo as a second expert. He is a very academically oriented nephrologist from Pune, consultant nephrologist at KM Hospital, reviewer for Indian Journal of Nephrology, Indian Journal of Critical Care Medicines and PLOS1, specialization in acute kidney injury, hemodialysis, thrombotic microangiopathy, and also in the kidney transplant unit, which he is heading at KM Pune. So I am Dr. Shailaja from Diabetes Dilemma. So today we are going to run first 15 minutes video of the basics of diuretic use, which Dr. Lobo is explaining to us. And then Dr. Lobo is live, who is already joined for discussion. And after this 15 minutes video, Dr. Hiremath will be giving his deliberation. So let's start about
diuretic class of drugs are a major part of all our prescription in our day-to-day practice. So different diuretics we use for different indications, and it's not only those patients with the end-stage cardiac problem or end-stage renal problem, but the major prescription for diuretics we use is to treat hypertension. In last few years, we have heard lot of discussions, lot of debates, lot of dilemmas about thiazide and thiazide-like diuretics. So we have decided to discuss the basic mechanism of action of different diuretics today in today's session of Diabetes Dilemma. I am Dr. Shailaja from Diabetes Dilemma, and with me today is Dr. Valentine Lobo, a famous academically oriented nephrologist from Pune. So welcome Dr. Lobo to Diabetes Dilemma session. So today we are discussing different diuretics which we use in our day-to-day practice. As we discuss where exactly in these drugs act, in which part of the nephron or the tubule, to understand the effects and the side effects, will you please explain different class of diuretics and the basic sodium water handling by a nephron and how these diuretics act? So I think we are just revisiting these basic mechanisms of different diuretics and also the sodium water handling in kidney.
Cannot understand the action of diuretics unless we understand how the nephron handles salt and water. The tubular filtrate or the glomerular filtrate which enters the proximal tubule has the same constituents as plasma, since it is a filtrate of plasma. So it contains sodium, bicarbonate and chloride and also water in the same concentrations as found in the plasma. Now once the proximal tubule, in this section, under the action of carbonic anhydrase isoforms 2 and 4 and the sodium hydrogen exchanger 3, a large amount of sodium, bicarbonate and water, about 65 to 70% of the components of the filtrate are absorbed. Because both sodium and water are absorbed, this section of absorption is called isotonic, that is the fluid entering the proximal tubule and that leaving the proximal tubule has the same osmolality as that of plasma, namely about 280 to 300 milliosmoles per kg. Now once this tubular fluid leaves the proximal convoluted tubule and enters the loop of Henle, it enters the descending limb of the loop of Henle, which is impermeable to salt and water but is freely permeable to water. So as water gets absorbed, the fluid descending in the loop of Henle becomes steadily more concentrated, reaching from about 300 milliosmoles per kilogram where it entered to about 1200 milliosmoles per kg at the hairpin bend of the loop of Henle. We know that there are both short looped and long limbed loops of Henle, and it is the long limbed loops of Henle which concentrate the fluid maximally to 1200 milliosmoles per kg. Now, as the fluid then turns and enters the ascending limb of the loop of Henle, a significant portion of this part of the loop of Henle is known as the thick ascending limb of the loop of Henle, and it is impermeable to water. It is, however, permeable to sodium, potassium and chloride, and this is mediated largely through a transporter called the sodium potassium 2 chloride channel, which is inhibited by loop diuretics, furosemide, torsimide and bumetanide. Now in the absence of the diuretics, again about 15 to 20% of the sodium and chloride is absorbed in this section with some amount of potassium of course, and as we saw, 65 to 70% was absorbed in the proximal convoluted tubule. Now we have an additional 15 to 20% being absorbed, but there is a difference. In the proximal convoluted tubule, both sodium, chloride and water absorbed, so the fluid did not change its osmolality. At the first time in the nephron, we have a dissociation of water and salt absorption. So we have a section in which sodium and chloride is being absorbed, but water cannot be absorbed. So the fluid, which had become concentrated in the descending limb by absorption of water, now begins to get diluted. In fact, it becomes even slightly more dilute than that of the original ultrafiltrate of plasma. So as it enters the connecting segment, which was formerly called distal convoluted tubule, this connecting segment receives a tubular filtrate, tubular fluid, which has an osmolality of about 200 to 250 milliosmoles per kg. Within this section, the connecting segment, is a sodium chloride co-transporter, which is inhibited by the thiazide and thiazide-like diuretics. Now, the remain already about 85% of sodium and chloride has been absorbed, and here an additional 5 to 10% will be absorbed in the absence of inhibition, and so the tubular fluid becomes even more dilute. So this segment is often known as the diluting segment of the nephron, since the osmolality under the influence of the absorption of sodium and chloride drops further, reaching about 50 to 100 milliosmoles per kg. The lowest value that can be reached is about 50 milliosmoles per kg, and this is the maximum dilution of urine that can be achieved by the nephron in the presence of a significant water intake. Now, as the tubular fluid then enters the cortical collecting duct, there is an epithelial sodium channel which is sensitive to the effect of aldosterone. It's important to remember that the epithelial sodium channel is at the luminal border of the principal cells, whereas the aldosterone receptor is at the basolateral membrane, and it requires a signal transduction through the cell. So drugs which inhibit aldosterone will act at the basolateral membrane, that's spironolactone and eplerenone, while drugs which inhibit the epithelial sodium channel like amiloride act at the luminal border here. Now, when sodium is absorbed under the influence of aldosterone, potassium is secreted in this segment, and so the nephron at this stage absorbs sodium while secreting potassium, and also in the absence of potassium, a certain amount of hydrogen ions are also secreted. Once the fluid passes further into the collecting duct, this segment of the collecting duct does not have any more channels to absorb any of the ions, and under normal circumstances is impermeable to water. But in the presence of arginine vasopressin secreted from the posterior hypothalamus, certain proteins called aquaporins, namely aquaporin 2, are inserted into the luminal border of the membrane in these cells of the collecting duct. Now, we have to remember that on the other side is the interstitium, which has received the large load of absorbed sodium and chloride from the loop of Henle. So, the medullary interstitium here is highly concentrated, up to about 1200 milliosmoles per kg, and when this segment of the collecting duct becomes permeable to water, then with a hypertonic medullary interstitium drawing water and a segment of the tubule which is permeable to water, under the influence of arginine vasopressin, large amounts of water can be absorbed and the urine will get concentrated, or the tubular fluid which goes on to form the urine gets maximally concentrated here to about 1200 milliosmoles per kilogram, which corresponds to the minimum amount of water that is required to be excreted in this situation, about 400 ml in an adult human being. So that is why 400 ml of urine is the minimum that can be passed. Below that, we call it as a pathological condition of oliguria.
Yes, I think, thank you. It's very nice to revisit the basic concepts. And so can we have some your views about different thiazide and thiazide-like diuretics? Is there a difference between hydrochlorothiazide, indapamide, chlorthalidone in their basic action, or maybe when we call duration of action or anything?
Right. So, the thiazide diuretics originally are those which contain the thiazide ring, and chlorothiazide was the initial one. Hydrochlorothiazide also belongs to that group. Metolazone is a bit in a class of its own. It has some specific properties, namely its ability to also inhibit carbonic anhydrase and act on the proximal tubule, while chlorthalidone is a thiazide-like diuretic, but it also has some very interesting properties. So, as far as structure is concerned, chemical structure is concerned, these might be called thiazide or thiazide-like diuretics, but they act on the same sodium chloride co-transporter in the same segment, the connecting segment of the nephron. As far as their individual properties are concerned, hydrochlorothiazide has a shorter half-life, about 8 to 12 hours, whereas chlorthalidone has a long half-life of about 20 to 30 hours, which allows a once daily dosing and makes it an ideal drug to use as an antihypertensive. Metolazone has some interesting properties. It is not a very powerful diuretic on its own, but it has a remarkable ability to potentiate the action of all the loop diuretics, and also it is the only drug in this class which can act in the presence of a following GFR. It is active until a GFR of about 30 minutes, whereas most of the other thiazide diuretics and thiazide-like diuretics will lose their action in the presence of chronic kidney disease.
Yes, so also I want to know about this, your comment about this hypokalemia and these thiazide diuretics, and because there is so much of which we will discuss again, can I have your comment about this?
Right. So, hypokalemia is associated with the thiazide diuretics and also with the loop diuretics. Where the loop diuretics are concerned, it's easy to understand. They are inhibiting the sodium potassium 2 chloride channel. So, absorption of all of these will be inhibited and these will be lost in the urine. Sodium, potassium and chloride. But with the thiazide diuretics, there is no potassium in the channel mentioned over there. So, the mechanism by which the thiazides and thiazide-like diuretics cause hypokalemia is an indirect mechanism. They deplete the intravascular volume, and as a result of this, what happens is that aldosterone secretion is increased, and we know that aldosterone is responsible for sodium absorption and potassium secretion. In addition, they increase the distal fluid delivery to that segment where sodium is absorbed by the epithelial sodium channels, and we know that in this section also potassium is secreted by the principal cells and the intercalated cells. So, the indirect effect of thiazides, increasing the aldosterone concentration and increasing the distal fluid delivery to that section where aldosterone will act, is responsible for the hypokalemia that is seen with these drugs.
Yes. And you also mentioned that chlorothalidone, because it's a long-acting drug and the drug lasts for 24 hours, it becomes a preferred thiazide-like diuretic when we treat hypertension. Yes. And sorry to use the word Lasix and Diator, but I think we understand better when we use these words. What's the difference between the Fluorescemide and the Tursimide when you come to mechanism of action?
The mechanism of action is the same. They both act at the same site. The important thing to remember about Lasix and Diator or Fluorescemide and Tursimide is that they need to reach the tubular fluid because they act at the luminal border. So there are specific organic ion transporters 1 and 3 which are responsible for delivering them to the tubular lumen. They act at the same point, but as far as the potency is concerned, Tursimide or Diator is twice as potent as Fluorescemide. So the dose needs to be half. So an equivalent dose would be 10 milligrams of Tursimide is equivalent to 20 milligrams of Fluorescemide or Lasix. The other difference is that the oral bioavailability is significantly different. Fluorescemide has very variable oral bioavailability, varying from 6% to more than 50%, whereas Tursimide is more stable. It is absorbed to the amount of 50 to 80% after an oral dose, and so it would be the preferred oral drug, whereas either of them could be chosen for intravenous use.
Yes. And what about these potassium sparing diuretics, which we use in very, end stage kind of a problem with the cardiac or the renal? Are there any other indications from your research? Can you comment on that?
So there is significant benefit about the potassium sparing diuretics. Among these, spironolactone and eplerenone. Eplerenone has less side effects because it is selective to the mineralocorticoid receptor, does not interfere with the androgen, whereas spironolactone has a lot of troublesome side effects because of the cross reactivity. Now, spironolactone and eplerenone have been used very successfully in the treatment of cardiac failure, and also they have been shown to have a good long-term prognosis. They also might be combined with the loop or thiazide diuretics to prevent the potassium loss that we mentioned a few minutes earlier. Finally, spironolactone is particularly effective, even more than the loop diuretics, in taking care of the ascites of cirrhotic patients. So that is a particular use where spironolactone is more effective than loop diuretics. There have also been studies which have now tried to use these drugs in retarding renal fibrosis, which has been linked to mineralocorticoid excess as a compensatory mechanism. So they have been shown to reduce renal fibrosis. The caveat to this is that they are potassium sparing, and as renal function decreases, there is a propensity to hypokalemia, so they have to be used with extreme caution and close monitoring. Also, many of the patients with chronic kidney disease will be receiving other nephroprotective agents like ACE inhibitors and angiotensin receptor blockers, which also increase propensity to hypokalemia. So, if combined with a potassium sparing diuretic, extreme caution is required to prevent a life-threatening hypokalemia.
So I think it was a very good kind of a revisiting the basic mechanisms of different diuretics, revisiting the nephron and the different parts, and how the sodium and water handling happens, and wherever all these diuretic drugs we are using, how it acts. So it was just revisiting our basic concepts, and thank you so much, Valentine Lobo. Yeah.
So we have Dr. Valentine Lobo and Dr. Hiremath here live for today's diabetes dilemma. So I request Dr. Jagdish Hiremath for his deliberation about what about chlorothalidone.
Am I audible?
Yes.
Okay, thank you, Dr. Shailaja. It was such a nice discussion about the loop of Henle and other things. I wish somebody taught me like that in my first MBBS days. My concepts could have been clearer. Thanks, Dr. Lobo, for that. What Dr. Lobo has essentially done is given you a mechanism how egg is laid. So now I'm going to discuss how to eat an omelette. That means we'll see how clinically these diuretics can be used. And we know that we should differentiate between loop diuretics, which we are rarely using for hypertension. The hypertension diuretics are actually thiazide-like diuretics. half a minute on this slide, because this would mean dissemination of knowledge. In our meeting in European Society in Munich, 4,000 interventional cardiologists were present in the main arena, and 2 hours were spent on measurement of blood pressure. So we must know the importance, each one of us, we have to spread the knowledge. So essentially the blood pressure measurement has to be in sitting posture. Both legs should be touching without crossed. Back should be resting. Arm, the tabletop and the heart should be at the same level. There should be no cloth on the arm. Tie the cuff and wait for a minute before you switch the cuff on. And then what you will get is the best method or the best measurement of your blood pressure and the pulse rate. Of course, you should not have had any stimulant like a tea, coffee, cigarette, or a big meal. And then probably you can give the best possible reading. I am encouraging a lot related to home blood pressure monitoring, because that has been shown to be the best parameter for final the target organ dysfunctions. The level of evidence, as we talk about, mathematics is 1A, that means 2 plus 2 still remains 4. And philosophy, karma, God becomes 2D. That is the worst kind of evidence. Physics is not bad. Chemistry can have mutation. And biology, the medicine that we practice, is 2B. That means whatever we discussed maybe a few years ago may not hold true today, because the science keeps changing and the science is in fact fluid. So that's what happened. In 2001, if you see, there was an octagon. Diuretics were sitting on the top, and all these other antihypertensives were around it. And the bold lines were good combinations and the dotted lines were bad combinations. Note, in 2001, there was no line between diuretics and calcium channel blockers. So this combination, as it is used in elderly, was practically unheard of in those days. Science evolved, and in 10 years later, diuretics became thiazide diuretics, because we are talking of hypertension. So the loop diuretics and the spironolactones are not used here unless it is a resistant phase 4 phenomena. So there is essentially thiazide diuretics, and beta blockers and all others, they had disrepute because of the bad combination. And the good combination remained ACE-ARBs and calcium channel blocker. And this is where there is a combination between CCBs and the diuretics. Then it became an octagon for that matter. Just the ABCD, ACE-ARBs together, calcium channel blocker, diuretics and beta blockers. And beta blockers were in a very bad disrepute by this time. So for non-compelling indications, practically it wasn't used. However, beta blocker, calcium channel blocker remained a good bold combination, especially of potency-wise. ACE-ARBs, calcium channel blockers were good. Diuretics could be combined with any one of them. And finally, most of our patients would be ACD, that means ACE-ARB, calcium channel blocker or diuretic. The important thing about hypertensive medicine, antihypertensive medicine, is that it may lower the blood pressure. If you use a very scientifically good combination which doesn't reduce blood pressure, it is of no value. Just like Rahane, if he could score runs, he could have been captain of India. But he cannot score runs anymore, so he's not in the team. That's what has happened to some of the weaker diuretics that were around. Now, of course, it is changed to just ACD, beta blockers are not there. And the thiazide diuretics have become the first line agents for management of hypertension. And it is, you have all heard about the Cochrane analysis, where they say that thiazide is the best first choice hypertension. And it is also supported by the Lionel Opie's book. So many other textbooks also support the notion that thiazides are the best. And our Bible in cardiology, Brownwald's textbook, also mentions that indapamide or chlorothalidone likely would have provided better CV protection than hydrochlorothiazide if used in one of the trials, which was the accomplished trial. And of course, guidelines, whether it is American, European, all of them support the notion that thiazide diuretic should be used. Thiazide-like diuretic, that means we are essentially talking of indapamide and chlorothalidone. Indian guidelines in 2019 also mentioned that chlorothalidone is preferred over hydrochlorothiazide as an antihypertensive agent. And the formula was simple. Under the age of 50, start with ACE or ARB. Older people start with calcium channel blocker or a diuretics to start with. Then combine the two, and if the combined effect is not good enough, then combine all three. So finally, for stage 2 plus, you would combine A and C and D, but the D was very much a part of the scheme. Chlorthalidone, does it become the best initial choice for a single drug therapy? Well, there is loads of evidence related to that. Many of the slides that I'm going to show is not to read the slide, but to explain to you or assure to you that whatever is said is through by way of evidence. So thiazide, like diuretic thiazide, hydrochlorothiazide, metolazone to some extent, indapamide. But chlorothalidone is preferred on the basis of a prolonged half-life. What happens if you use a drug like hydrochlorothiazide, that it will work for the initial 6 to 8 hours, and after that, in the next, say maybe 18 hours, there is no antihypertensive effect at all. But chlorothalidone, being long-acting, does that job, and also after a few weeks, starts working like a vasodilator and ceases to be a diuretic effect. So if you look at the effect of clinical efficacy of chlorothalidone, ALLAT was a very big trial. It was a path-breaking trial for management of blood pressure. It did away with beta blockers to a large extent, and it clearly showed that the triangle, that is the best effect, was with chlorothalidone as compared to lisinopril and amlodipine. So we all know that amlodipine works very well, but in this trial it was clearly shown over a period of almost 6 years that chlorothalidone was in fact the best antihypertensive. Not only it did that, but when compared with the hydrochlorothiazide, the red bar is the chlorothalidone, the blue one is hydrochlorothiazide. And even if you see here, the green one is hydrochlorothiazide. Very clearly it shows that it controls systolic blood pressure, diastolic blood pressure, nighttime systolic blood pressure, and also 24-hour control, very clearly in favor of chlorothalidone. And this would be a repetition, so I would skip that and go to the next one. There is a direct comparison with chlorothalidone and hydrochlorothiazide. If you look at the systolic numbers, diastolic numbers, and the serum potassium numbers are all favoring chlorothalidone. Hydrochlorothiazide is slightly safe as far as hypokalemia is concerned, probably because of its weaker action and a shorter duration of action. Chlorothalidone clearly has a superior BP control other than indapamide. Some of them are direct evidence and some of them are indirect. Systolic BP reductions -14 whereas -10. Nighttime BP control was much better with chlorothalidone because obviously longer action. And goal BP achievement was 69% systolic blood pressures compared to 61 in the indapamide group. It is also better by way of CV risk reduction, as I said, early morning protection, CV risk, stroke reduction, reduction in mortality. Everywhere, in fact, chlorothalidone scores over indapamide in many of the aspects. Now we talk of the pleiotropic effect or just beyond hypertension. We are treating hypertension, but the effect beyond hypertension or the pleiotropic effect. I feel pleiotropic effects are like God. You have to believe that rather than actually having the proof of it. So whether it is inhibition of platelets, angiogenesis, vascular permeability, all these are proposed mechanisms by which benefits beyond hypertension control are obtained by use of chlorothalidone. And this is very clearly evident with the heart failure and CV event reduction. If you look at the combined cardiovascular disease and heart failure, whichever subgroup it is, under the age, men, women, black, non-black, diabetic, everywhere it favors chlorothalidone. Everywhere it favors chlorothalidone. So obviously heart failure reduction with a diuretic is logical also. It is to be anticipated also. And of course, it relates to better control of hypertension. So chlorothalidone versus calcium channel blocker or ACE inhibitor, we expect that ACE inhibitor would be more potent than diuretics in preventing heart failure, but it's not so. The thiazide type diuretic chlorothalidone was superior in this trial in the ACC/AHA guideline in preventing heart failure. Amlodipine, of course, would be a relative contraindication in heart failure. A SHEP study, which was one of the oldest trial known about for chlorothalidone, very in the 60s, and it clearly showed a great stroke reduction with chlorothalidone, because in the SHEP there were the chlorothalidone was used as one of the trials. So all in all, I feel that the use of chlorothalidone in hypertension management, or the effect of chlorothalidone in hypertension management, is almost like an elephant in the room. We cannot deny the fact that this is an important drug, and it should appear in most of our prescriptions where at least stage 2 hypertension is concerned. Coming to specifically of diabetic hypertensives, recommended by textbook, it clearly shows that chlorothalidone is the preferred antihypertensive for cardiovascular benefits. And in ALLARD's trial and various other trials, it is the same thing which is recommended once again. So what are the treatment strategies in people with diabetes recommended by guideline is that you should start with a combination of RAS with CCB and a thiazide-like diuretic. European guidelines now recommended right from stage 1 for stage 2 hypertensive, a fixed dose combination of 2 drugs to start with straight away. So in this, we should think that when you start
Dinesh?
to make a triple combination. Original articles where this is a ALLARD extension of diabetes extension study. A very large number of patients followed for almost 7 years. Chlorothalidone has the lowest risk reduction and highest risk reduction and lowest CV mortality, total mortality, non-CV mortality, and stroke when you used in diabetic population. So in chronic kidney disease, just now it was mentioned that these are slightly weaker diuretics, and the notion has been all these days that change from thiazide diuretics to loop diuretics when the GFR falls. I'm sure Dr. Lobo will explain to us in greater details once I finish my presentation. But there is a trial related to that. There's a CLIC trial, which was chlorothalidone for hypertension in advanced chronic kidney disease. Normally in such disease, we don't use the chlorothalidone. We end up using loop diuretics. But this study clearly shows that there was a higher reduction of systolic blood pressure with chlorothalidone. Of course, is compared to placebo. On top of it, the normal treatment which was going on. And also there was a albumin to creatine ratio which was much better with chlorothalidone. Moment you stop the treatment, it again climbs back to the original values. So reiterating that, yes, it can be used in chronic kidney disease as well. So in conclusion, among patients with advanced CKD and poorly controlled hypertension, chlorothalidone therapy improved blood pressure control at 12 weeks as compared to placebo. So it can be a real valid option, which we were not thinking all these days. So looking at the thiazide like diuretic, especially chlorothalidone, it could be the first line low dose which can reduce mortality, stroke, and heart attack. Thiazide diuretics are recommended by various guidelines as well as international books. Chlorothalidone is preferred on the basis of its prolonged half-life, and the PRUEL trial, it's a large load of evidence favoring chlorothalidone actually. Various clinical trials show chlorothalidone benefits in prevention of severe outcomes like heart failure, stroke, and mortality. It's also recommended in treatment of diabetic hypertension. And recently, the CLIC trial shows that there has some usefulness in chronic kidney disease as well. So 2003, Bachchan looked like this, and in 2021 he looks like this, but continues to enthrall all of us. Similar, the story is Chlorothalidone. In 60s, it was a diuretic of choice, and in 2022 also, it is a diuretic of choice in the treatment of hypertension. I shall stop here, take some questions and discussions. Thank you.
Thank you, Dr. Hiremath. For as usual, it's a very lucid and explanatory talk about Chlorothalidone, revisiting and the basic things about. So it's a preferred drug for as an antihypertensive. There are some questions. So before I go to some important points, let me take few questions. So there is.
I think the difficult question should go to Dr. Lobo.
So Dr. Ajit More is asking, after how many days of initiation of Chlorothalidone we will start getting results. So even I wanted to have this comment that there is a perception among all ourselves that Chlorothalidone, is a weaker diuretic. And all your studies which are showing, including SHAPE and ALERT and everything, that it is such a good antihypertensive and can be used as a first line. So can you just have your comment, or maybe Valley, you can also, or Dr. Lobo, you can also have your comment.
The diuretic effect might start with the first dose, but the antihypertensive effect will take 4 to 5 days. And the best antihypertensive effect will take about 2 to 3 weeks, when actually starts working like a vasodilator as well. So it's a drug you have to be patient with, and then finally it will, in a few weeks' time, it will have its maximum effect. But so is true of many others. They like ARBs and other, they all mature over a period of weeks.
Okay. So there is one question, I think is for Dr. Lobo. What is safe diuretic for patient getting recurrent hyponatremia? Dr. Lobo, you want to comment? You need to unmute yourself.
Yeah, am I audible?
Yeah.
Yes.
Yeah. So I think the question was on patients getting hyponatremia.
Yes.
So yeah, the loop diuretics are safer than thiazides. In fact, thiazides over there, that is one situation where thiazides have been known to produce hyponatremia, and loop diuretics, which actually cause free water excretion, would take care of hyponatremia. Now, all this is true when we are talking about hyponatremia that is dilutional. Any diuretic, both loops and thiazides, can produce hyponatremia by causing an overall intravascular volume depletion along with sodium depletion, where the sodium depletion is more than that of the water depletion. The drug which is a drug of choice to treat hyponatremia is the Vaptans, that is tolvaptan, which is available orally. So this group, which are known as the aquaretics, which are the V2 receptor agonists like tolvaptan, they would be the safest diuretics to use if one is treating hyponatremia.
Okay. There is one question by Dr. Suryakant Pandit. Till what stage of CKD we can use Chlorothalidone? I think we just heard about the CLIP trial, which was shown by Dr. Hiremath. Dr. Lobo, you want to comment?
Yeah, the CLIP trial is new. Even I cannot explain this mechanism by which it was clearly shown to have an effect. Usually, we would use them up to a GFR of about 30, a calculated GFR. Below 30, it is generally said that the thiazide diuretics, with the exception of metolazone, do not act. Metolazone acts even to a later stage. But yeah, the CLIP trial gives us all something to think about.
Okay. Dr. Hiremath, you want to comment?
No, true. It was a smallish trial, about 160 patients. So, though the results are startling, they are totally going away from what we thought in the past. So, more experience and more evidence would be important. But it's a point to note that you don't have to really stop. You may add another diuretic if you want. And if you are already giving the patient a, say, thiazide-like diuretic, there is no need to really shift and change to a loop diuretic.
There is a lot of importance for 24 hours blood pressure monitoring, ambulatory blood pressure monitoring, nighttime blood pressure. And there are a lot of good studies showing that 24 hours blood pressure and nighttime blood pressure is actually independently reducing cardiovascular risk as well as mortality. So maybe the effect of 24 hours acting drug, does that have any value in what time we should give the drug? Because there is a question from Dr. Umerji that he's asking whether chlorothalidone should be given in the morning or at night.
Any diuretic we would prefer to give in the morning rather than at night.
Basically, this is discussed world over very vociferously in all the meetings. And there is Dr. Balkis, who is now the father of hypertension management world over, very strongly advocates night dosing. When you are treating with a single tablet, night dosing, even if it is a diuretics, like the antihypertensive diuretic that we use, say hydrochlorothiazide 12.5, chlorothalidone 12.5, 6.25, or 1.5 of indapamide, they produce hardly any diuresis. So one shouldn't be shy of giving it at night, explaining the patient at least initially you will have some diuresis, because after a few weeks their mechanism of action changes and they become vasodilators. So if it fits in your schema of things, probably it would be easy to write it. Suppose there is a combination of, say, telmisartan with a diuretic. Suppose it is given at night, it would cause a nice physiological dipping at night. It would prevent the early morning surge, and it will then continue to work throughout the day. So that's why it is all the events that happen at night are very well controlled if you give the tablet at night. So there is a big, shall we say, thought process related to night dosing. War is on, but I personally do use night dosing when it comes to giving single dose, or if it is convenient for the patient. Suppose in the office he finds the diuresis difficult to manage, then there is no problem at all in giving it at night, and it will still work very well, and it will produce physiological control of blood pressure.
Yes. Dr. Shashikant Gazre is asking, what is the maximum dosage of chlorothalidone which can use? Dr. Lobo, you want to take this?
Yeah, it said 50 to 100 milligrams have been used.
Okay.
I have rarely used anything beyond 25.
Yeah, same here. No personal experience, but the guidelines do say 50, up to 50.
No, because you see more tougher nuts to crack. So for me, management of hypertension means I have gone maximum to 25, that to 12.5 being the commonest.
12.5 is the commonest. Yeah, sometimes we even start with 6.25.
Yes.
I have used 50 occasionally. And one condition where I have not used chlorthalidone but other thiazides, in diabetes insipidus, I have gone up to 50 frequently. Okay. Nephrogenic diabetes insipidus.
In resistant heart failures, wherein to produce theoretically the sequential nephron blockage, I have used up to 25 milligrams of chlorothalidone to good effect. Of course, on board are the loop diuretics and aquaretics and everything. So it's a kind of a masala that works.
Yeah. I agree with you. That is one of the best combination: aquaretic, loop diuretic, and thiazide.
I think Dr. Gazre, you can have your comment also in the chat box. Since we are on the doses, what about 6.25 of chlorothalidone? So we use it as a combination in the heart failure or as an antihypertensive?
No. This dosing is obviously for hypertension, and it can never be a standalone treatment, because if somebody needs only that much dose for control of blood pressure, probably it doesn't need anything. So it is already in combination, maybe with, most of the time this combination is with the ARB, and of course we have used it as a triple combination with ARB, with a calcium channel blocker and a chlorothalidone. So there 6.25 works very well. And say somebody who is about stage 2 and not stage 2 plus, this combination will work.
Okay, and since we are your combination treatment for hypertension, actually the first time it pushed for combination, then it was followed for heart failure, diabetes, everywhere in the guidelines. Dr. Hiremath, you were actually pioneer in doing research about half dose triple combination of drugs. I think he's lost.
Yes,
So,
correct.
can
So
you comment
actually,
about?
that trial was unique because it brought in this concept for the first time, and it had what 20 milligrams of telmisartan, 2.5 of amlodipine, and I think 6.25 of hydrochlorothiazide. So very minimal doses, and this was comparison with 40 milligrams of telmisartan and 12.5 of hydrochlorothiazide, which was an imported original molecule. So comparison of this triple Indian combination versus a Micardis plus, which was a original molecule, and it worked off very well because the amlodipine part, I think, probably adds more potency to the combination, and it is wonderful for a somebody who's stage 1 where you want to just control numbers. There you are not bothered about the long-term effects and the target organ dysfunction. See, somebody is 35, he's sitting on 140/90, he's not a disciplined man, or he's already disciplined and cannot lower it further. Then this combination works wonderfully well. For some years you can go on with it. And then of course you start thinking then how to prevent the other aspects and all. So it's an initial treatment. It has worked very well for me.
Yes, I think, and then of course, so many guidelines came about these initial low dose multiple drugs in one tablet. And of course, it works wonderfully in clinical practice. We are using a lot of such combinations as an anti-diabetic now for glucose management. Dr. Pankaj Patwari is commenting that chlorothalidone is not in heart failure management as it doesn't offer mortality benefits. Your comment, Dr.
Okay. No, it is not in the management of hypertension, but if you use it well in hypertensive individuals, it will prevent heart failures. That is what it means. That in the long run, it is a preventive aspect of the molecule for better control of blood pressure, also related to the fluid management. So it is a drug which is a, shall we say, preventive kind of a drug. And all these trials like the ALLATs and other things, they talk of the same thing. This patient is not in heart failure, he is hypertensive, and you are treating him with amlodipine, you are treating with chlorothalidone or ACE inhibitor, then the prevention of heart failure is best by diuretic like chlorothalidone.
Yes, and as we see so much of heart failure just by diagnosis of diabetes in our patients, I think it becomes more relevant to use such drugs in the initial stages when we are treating hypertension with diabetes.
And more so also related to the diastolic heart failure.
Yes, yes. So there's Dr. T.V. Narayan Rao. His comment is indapamide was supposed to be metabolically neutral compared to chlorothalidone. Your comments, please. I will want to. Okay, say first you go.
No, let him go. Practically, I think we are using quite small doses. So really metabolically neutrality doesn't matter. I have not seen any say a diuretic causing lipid problems or anything. We don't even think of it because the doses are very small. But these theoretical differences are known, and on paper, probably indapamide is metabolically more neutral. It is used in very elderly, so obviously it is going to be safer on that aspect also. But as I said, in practical management, I personally don't see any difference between the two.
I think there was a lot of discussion about hypokalemia, that maybe that question was related to that, which happens with, I will say everything together, thiazide and thiazide-like diuretics all have been shown to create slight hypokalemia, and there's increased incidence of new onset diabetes in patients who are more prone. But like trials like SHAPE or ALLAT, everyone has shown that ultimate outcomes of cardiovascular are not increased those who get new onset diabetes.
True.
And also that makes more relevant this combination of telmisartan and thiazide-like diuretics, whether indapamide or chlorpropamide, which actually treats this hypokalemia. And if you treat hypokalemia induced by these diuretics, that impaired GTT can be reversed. And there are lots of trials and studies which show that. So this combination becomes more relevant in patients of maybe impaired glucose tolerance or those who do not have diabetes, the telmisartan plus chlorothalidone.
It could be said the other way around also, that whatever hypokalemia is caused by the diuretic is kind of counteracted by the telmisartan effect of hyperkalemia.
And there is one more thing that all the diuretics produce, and that is hyperuricemia. And the sartans have a uricosuric effect. So they slightly offset that also. So one more metabolic
So that's what I feel. There is not much difference between indapamide and chlorothalidone and thiazide. So about this metabolic effect. Dr. Deepak Patel is asking which is more effective, aldactone or chlorothalidone in heart failure. Dr. Lobo,
Okay.
let Dr. Hiremath take it. It's on heart failure. So he'll be
Heart
the best.
failure, there is no doubt we have to use spironolactone. It's one of the foundational therapies of heart failure. And there the effect is not of the diuretic, it is more of the remodeling of the heart or fibrosis.
hello. Dr. Lobo, can you hear me?
Yeah, I can hear you, ma'am. But I think Dr. Hiremath has got disconnected.
Yeah, I know. So there's just one. Yes,
He's back.
yeah. So
as I said, for heart failure, no doubt spironolactone with a loop diuretic.
Yes. So there is one discussion which happens about systolic blood pressure and diastolic blood pressure, and we know both are independently has an effect on cardiovascular outcomes, mortality, strokes, and infarct. So what about these elderly people where we say that too much decrease in systolic blood pressure is not good? So is there a cutoff for elderly means I think above 80?
JNC 8 has kept a target of 10 millimeters higher for the elderly, 150.
Okay. So maybe I think 140/90 or that target holds true.
Actually, the sprint trial brought in a different dimension. And now they say that even for an elderly, try to control it to below 135, provided there are no symptoms. If the person is getting symptoms, then allow it to be 140 or so. So your target should be below 135. Say if somebody has kidney disease or somebody has heart failure, then more so you have to control it below 135. That is one aspect of it. So you keep targeting the systolic blood pressure to your best advantage. And whatever happens to the diastolic, keep observing. If it is going below 60, that is the time probably you should not lower it any further, systolic any further, because both of them go down a little simultaneously. So below 60 in elderly people, there could be coronary hypoperfusion. So diastolic cutoff for lower blood pressure is 60. Systolic, as I said, control it to the best possible and keep watching for symptoms of postural hypotension.
Yes. So, and just a passing remark, because there was a question and which I want from Dr. Hiremath about that association of skin cell carcinoma with thiazide, which was seen in one of the registry, and European medical agencies said about it. They don't ask to stop those who are on thiazide diuretics, but is there a difference between thiazide and chlorothalidone here?
See, we are in an era of computerization. So any statement that you make, there will be a statement which is supporting it and opposing it. I look at it this way: if in my 35 years of practice, if I have not seen a single skin carcinoma related to, then obviously it is bound to be very rare. If it happens, then I might think of it because I have read about it. But I don't think it is a stray report related to trials. And in practice, I have hardly seen or have hardly seen any colleague discussing about it.
Yes, actually, even I heard it for the first time. So many times we read literature about chlorothalidone and thiazide like diuretics, but I don't think it's like pioglitazone, which has a lot of discussion happened about its bladder cancer or effect. But except few countries, I think it is on much use. Actually, it showed a prevention of strokes in elderly people with IGT, a load of pioglitazone. So good drugs, as you said, we need to say good things about it and also value the expert opinion. not only the computer generated information.
Absolutely.
Yes, thank you so much.
ARBs were implicated in some cancers, but
Yes.
it's no longer true.
Yes. So thank you so much for that, wise words, I will say, about such comments. Now there is one question. I think I will take this last question and then your comments to end today's session. Dr. Jagdish Shah is asking, when systolic is 170 and diastolic is 60, how to manage?
Send the patient to someone else. I think that's the best. What I want to say is that it's a difficult situation to handle. 170 is more risky by way of stroke. Those as well target it better. Suppose somebody gets into coronaries, maybe you can manage it. It's easier or lesser complications as compared to stroke. So my targeting such a person elderly would be 150. I would try to get the systolic to 150 by whatever methods I have, and then close my eyes towards the diastolic blood pressure.
Okay, thank you. So I think Dr. Shah, I think he agrees with Dr. Hiremath. Dr. Pradeep Gupta has a comment about the side effects of thiazide like diuretics, about uricemia, glucose intolerance and lipid disturbances, and we discussed about it. So Dr. Pradeep Gupta, I think you got what you were suggesting. Dr. Pradeep Gupta has again said that the doses which we are using are as a vasodilator, this diuretic. So can be given at any time of the day. I think this is related to your comment about the nighttime dosing. Yes, so I think we are at the end and I would like to finish today's session. So any last comment? First, Dr. Lobo about chlorothalidone.
I think it's been a learning for all of us. I do use chlorothalidone, but the CLIC trial is obviously something that we should look at and hope that we will get even more studies of that sort, which will make its role clearer in management of hypertension in CKD. I agree fully with what Dr. Hiremath said, that we would not stop it, but we might add loop diuretics to the thiazides as the GFR falls.
Yeah. Before I thank both of you officially, let me thank all the academic partners of Diabetes Dilemma, today particularly IPCA. And also I will like to, Dr. Hiremath, are you there? I think we have lost him just now. Has he joined back?
He's there.
Okay, yeah, by the time he joins, let me tell my viewers that the initial 15 minutes videos of basic actions and how the sodium water balance, which was so beautifully explained by Dr. Lobo, is available on Diabetes Dilemma YouTube channel. So one can go on Diabetes Dilemma YouTube channel and you can watch this video, because even we recorded, I had to watch it 3 times and every time I am understanding some new thing. So I think we need to watch it again and again to understand it correctly. And so it is there on Diabetes Dilemma YouTube channel, and you will be getting such basic information videos now on this Diabetes Dilemma YouTube. At the same time, if someone wants to watch the whole episode, that whole today's session, which is available on diabetesdilemma.com web page. I will like to officially thank Dr. Hiremath because in his busy schedule, as usual, he was thorough and he took a lot of efforts and gave his expert views as well as the presentation about chlorothalidone and his own opinions, which we are getting a lot of benefits with these expert comments and expert discussion with the experts. Thank you, Dr. Valentine Lobo, as being an expert at Diabetes Dilemma, taking out time for the video and such a beautiful explanation, which I'm sure you'll getting more comments on this YouTube video of yours. Thank you, Dr. Lobo. Thank you, Ivka. Yes, thank you.
Thank you.